Good morning and welcome to Medicine Grand Rounds. It's really my honor to introduce one of our own, Nicole Rogus-Pulia. Dr. Rogus-Pulia is our Grand Round speaker today. She took her undergraduate degree at Marquette and then an MA in speech-language pathology at the University of Iowa, and then took her PhD in communication sciences and disorders at Northwestern. Since that time, she undertook postgraduate fellowship in the Women's Health Postdoctoral Fellowship Program here at the VA, and undertook an Advanced Geriatrics Fellowship at the VA. During that time, she was an adjunct assistant professor in the Division of Gastroenterology and Hepatology, but in 2016, we were very fortunate to recruit her onto our faculty as an assistant professor in the Division of Geriatrics and Gerontology in the Department of Medicine. She's also an assistant professor in the Division of Otolaryngology, Head and Neck in the Department of Surgery. She serves as adjunct faculty in the Department of Communication Sciences and Disorders. She's director of the Swallow Strengthening Oropharyngeal or STRONG clinical demonstration program here at the VA, and is a research health scientist with the GRECC here. She's already published 18 papers and 2 book chapters on her area of expertise, and likewise is currently supported by a T21 VA Phase 3 grant entitled VA Intensive Dysphagia Treatment Model Clinical Program. She's also supported by the Alzheimer's Disease Research Center pilot grant, and in the past received funding from the American Speech Language Hearing Foundation. She's an active clinician, spending 25% of her time on clinical service as a speech-language pathologist in the Swallow service in the Division of Otolaryngology. In addition to that, she's active nationally and regionally with the Wisconsin Speech Language Hearing Association, and nationally she's involved with the American Speech Language Hearing Association and the Dysphagia Research Society. She reviews for 10 journals and recently was named the editorial board of the Journal of Speech Language and Hearing Research. She's been an active educator as well at all levels, clinical and classroom, and she's taught medical students, graduate students, undergrads, and clinical fellows. She's received a number of awards along the way, including most recently the Sumito Okada International Fellowship Award from the Dysphagia Research Society and the David Whistler Memorial Research Award here in our Division of Gastroenterology and Hepatology. She's given a number of talks locally, regionally, and nationally, and even internationally. And as such, it's really an honor and a privilege for us to have her provide grand rounds for us, entitled Preserving the Joy of Eating, Rethinking Dysphagia Management in Dementia Care. Please join me in welcoming Dr. Rogus-Pulia.
Thank you so much, Dr. Page, for the introduction. I wanted to start just by asking you all in the audience to see if you can estimate the number of times per day you think we swallow. And I'd like you to just shout it out. How many times do you think in a typical day you swallow? Anyone? 1,000. Anyone else? 22,000. Active swallowing. Yeah, so I have the front row here, dysphagia experts, so a little bit of cheating going on. But we're in that 600 to 800 range for swallows per day. And when we swallow, we're not really thinking about it, right? It's automatic. It's just something that we do without really having any conscious thought around it. Being raised in an Italian family, food has been the center of my life from the time I could have my first bowl of pasta. And I'd like you all to just take a few seconds now to think about, during a typical week, how many of your interactions with others involve eating and drinking. So if you reflect on this, think about the meal that you prepare for your family that brings you together at the end of the day. And what about meeting that friend for a drink and having the chance to catch up? How about enjoying a bowl of popcorn when you're watching a movie? Or meeting friends at a new restaurant that you've been waiting to try? How about indulging in cake on your birthday? Or sharing a lunch and having a meeting over lunch? And more recently relevant, gathering together around a Thanksgiving meal with your family. The holidays involve meals, such a huge part of how we come together with the people that we care about. So now, think about if swallowing was difficult for you, if you had trouble with swallowing, how that would impact all of these interactions in your daily life. So imagine that you're sitting at the Thanksgiving table with your family, and you're swallowing, you feel like things are sticking in your throat. You have to get up from the table and run to the bathroom to spit that food out. Or you can't even swallow your saliva, so you have to walk around in your daily life with a cup so that you can spit out your saliva. How would that affect your interactions with others and your confidence? So I think we've established that swallowing has a very important role in quality of life. Today, I'm going to talk to you about dysphagia, or difficulty swallowing, in a specific patient population, patients with dementia. And my goal is to have you rethink the way that we currently manage dysphagia in this population, and hopefully walk out of here with some new perspectives. I have no disclosures. So my goals for this talk are to make sure that you have information you can apply clinically. And dysphagia is something that will apply to pretty much every specialty within the Department of Medicine. So whether you're a critical care physician, an infectious disease physician, a pulmonologist dealing with pneumonia in an older adult where dysphagia is likely a contributor, a rheumatologist seeing patients with Sjogren's syndrome or scleroderma who are likely to have dysphagia, a gastroenterologist who's trying to figure out, is it oropharyngeal dysphagia or esophageal? And what about a primary care physician or a geriatrician dealing with dysphagia in older adults or patients with dementia? Or an oncologist treating a patient with head and neck cancer who develops dysphagia post-treatment? Regardless of what your focus is, dysphagia does have application to your practice. And so when you leave here today, I want you to be able to define swallowing impairments that occur in patients with dementia, to be able to discuss the health consequences of untreated dysphagia, and to be able to improve dysphagia management by implementing some changes to the current processes that we have through early intervention, focus on goals of care, and an interdisciplinary approach. In order to meet these goals, we'll have a variety of topics that we'll cover. First, I'll give an overview of dysphagia and its consequences. And then we'll focus specifically in dysphagia in dementia. We'll talk about the prevalence of comorbid dysphagia in this population, specific swallowing impairments that we observe, the underlying causes of these swallowing impairments, potential intervention targets, and then also special considerations for late-stage dementia. We'll wrap up with a summary and future directions. The term swallowing refers to the process of moving material through the mouth, throat, and esophagus into the stomach through a series of muscular actions. In contrast, dysphagia refers to difficulty moving food, liquid, secretions, and medications into the esophagus. Now I put this up here because you'll be having a quiz at the end of the talk on all of your cranial nerves, so if you can think back to gross anatomy. I really just wanted to make the point with this slide that swallowing is a very complex process that requires precise coordination of over 50 muscle pairs and 6 cranial nerves. It was traditionally thought that swallowing was an invariant reflex, but thanks to more recent fMRI studies, we now understand that the swallowing neural network is actually quite diffuse, and that the swallow response is a patterned response rather than a reflex. While there is brainstem control, this process is modulated by the cortex, depending on what you're swallowing. So the volume, the viscosity, or the taste of what you're eating will influence the swallow response. There are 4 phases within the swallow. These are not discrete, however. They do tend to overlap. In dysphagia, when we're talking about the food or liquid that's being swallowed, we refer to it as the bolus. And you'll see the bolus here circled in red. The first phase of the swallow is called the oral preparatory phase. This is where if we have a solid bolus that requires mastication, you'll use your tongue to move the bolus in between your teeth back and forth to chew it, and then also integrate saliva with the bolus. Saliva has amylase in it, which begins the digestive process in the mouth. Once the bolus is adequately prepared, the next phase of the swallow will begin, called the oral phase. In the oral phase, the oral tongue comes up, and the tip and sides of the tongue contact the roof of the mouth or the hard palate. The tongue then moves sequentially to contact the hard palate and move the bolus back towards the pharynx. It also creates positive pressure on the bolus as it's moving it into the throat. Once the bolus reaches the back of the oral cavity, there are sensory receptors located in the anterior fascial pillars as well as in the base of tongue that send sensory signals to the medulla in the brainstem. The nucleus tractus solitarius receives this sensory information and then initiates a motor response in the nucleus ambiguus. Once this motor response begins, we call this the pharyngeal phase of the swallow. During the pharyngeal phase, there's reconfiguration of the pharynx so that you can protect your airway and also open the esophagus. And there's a series of events. So your velum or your soft palate elevates to close off the nasal cavity from your throat. And I'm sure you've all had the experience where you're talking and eating and you have some food or liquid come out of your nose. So that process didn't work well in that case. The base of tongue will come back to contact the posterior pharyngeal wall, again creating more positive pressure on the bolus, moving it through the throat. The hyoid bone and the larynx will elevate and move forward, and this helps to close the airway. So this helps the true vocal folds to come together, the arytenoid cartilage to tilt anteriorly and contact the base of the epiglottis, and then the epiglottis will invert over the top of the airway for that last layer of protection. As the hyolaryngeal complex moves up and forward, it pulls the cricoid cartilage away from the posterior pharyngeal wall, which helps to open the esophagus. The cricopharyngis muscle also relaxes, allowing the bolus to enter into the esophagus, which begins the esophageal phase. When we're thinking about the specific kind of impairments that can occur in the swallow, and you think about these different stages and how complex it is, something that goes wrong biomechanically in the swallow can result in different clinical outcomes. One of our main concerns is the safety of the swallow, or whether or not there's airway invasion. If you look at the image on the left, in the red circle, this is a sagittal image of the oral cavity and throat and larynx on a video fluoroscopic swallow study. And the dark material is the barium that's being swallowed. So inside the red circle on the left, you'll see that a little bit of this material is entering into the top of the larynx, or into what we call the laryngeal vestibule. And we call this penetration. In contrast, on the right side, you'll see inside the circle, some of that material has moved down below the true vocal folds and into the trachea. And so now we would say it's been aspirated. In addition to the safety of the swallow or airway invasion, we also have concern over efficiency. So we want to know whether there's any material left in the oral cavity or the pharynx after the swallow, and we call that oropharyngeal residue. And you can see in this image here, the arrow is pointing to the residue in the pharynx, and in this case, sitting in a specific area of the pharynx called the piriform sinuses. These are two pockets in the throat. Another common place for material to accumulate is the vallecular space, which is where the base of tongue meets the epiglottis. And as you can imagine, once you're done swallowing, you have to breathe again. So you'll open your airway, and so if this material is in your throat, it's at risk for moving into the airway and being aspirated. So this is an example of a normal swallow on video fluoroscopy. And what I'd like you to notice here, the arrow in red is pointing to the esophagus. And you'll notice that the black, or the barium, is moving quickly through the mouth and the throat and into the esophagus. There's no material entering the airway and no material left over in the mouth or throat after the swallow. So this is what we would consider to be normal. This is also normal, but normal for an older adult. So just some slight changes in the swallow that we observe with advancing age. In the red circle, if you watch at the height of the swallow, you'll see just a small amount of material penetrated into the laryngeal vestibule. And we observe as people age that penetration is more frequent. You can imagine that if material is penetrated more frequently there is an increased risk that it will be aspirated. This is an example of an abnormal swallow in a patient with dementia. And you'll see inside the red circle again that some of that black material is moving down into the airway and below the level of the true vocal folds. And in this case, the swallow is actually a little bit slow. So before we see that upward-forward movement of the hyolaryngeal complex, some of that material is already in the airway. So we didn't get that sort of trigger of the pharyngeal phase quickly enough in this case. So what are the consequences of mismanaged or untreated dysphagia? We know that dysphagia has been shown to be an independent predictor of hospital readmission to pneumonia, both aspiration pneumonia and non-aspiration pneumonia. So I think when we typically think of dysphagia, we think of aspiration pneumonia. But we also have chronic aspiration of our saliva that can happen when we're dysphagic, and that can lead to some of these cases that maybe haven't been clearly identified as being aspiration pneumonia. Dysphagia also contributes to malnutrition, dehydration, and also to quality of life, as we've already discussed. Patients with dysphagia are at increased risk for hospital readmission, have longer lengths of stay, which increases costs associated with their medical care. And there's also increased caregiver burden for individuals taking care of older adults with dysphagia. And finally, patients with dysphagia are at increased risk for mortality. However, it's important to remember that dysphagia itself is not a disease. It's physiologic dysfunction that crosses a variety of medical etiologies, which is why it has direct applicability to each of you in your practice. So now that we've reviewed normal swallow function, what we can expect in terms of swallowing abnormalities and clinical outcomes, we'll move into focusing into one of these specific populations, patients with dementia. We know that 1 in 10 individuals in the U.S. over the age of 65 years has an Alzheimer's disease diagnosis. This means that for each of you in this room, there's a very good chance that dementia will be an issue for you with a loved one or a family member in your lifetime. And therefore, dysphagia will also be an issue. We know the prevalence of comorbid dysphagia in patients with dementia ranges from about 32 to 75%. And the reason for these wide estimates is the way that dysphagia is defined. So in some of these studies, it's self-report, and in others, there's objective assessment of swallowing through video fluoroscopic swallow studies. Also, the severities of dementia range between studies and the settings that these patients reside in. So patients who reside at home versus in long-term care will have different levels of dysphagia. It's estimated that about 53% of all patients in long-term care with dementia have dysphagia. 81% of patients with Alzheimer's disease report difficulties eating as compared to 27% of healthy adults. And about 50% of these patients will lose the ability to feed themselves within 8 years of diagnosis. So what are the consequences of dysphagia specific to the dementia population? We know that bronchopneumonia is the most common cause of death in Alzheimer's disease. And malnutrition occurs in over 50% of long-term care residents with dementia. And this is thought to be definitely attributable to poor oral intake. Dysphagia at discharge for patients with dementia is associated with increased risk for pneumonia, malnutrition, feeding tube placement, longer length of stay, and discharge to a facility. So I'd like to stop here for a minute just to let you know this is one of the key points that I'd like you to walk out of here with today. You'll see here that when we look at the different issues that happen in the dementia progression, we see dysphagia placed in the category of terminal stage dementia. I'm going to show you some studies today that support the start of dysphagia in the early phases of dementia and the progression of dysphagia along with dementia progression. As part of my pilot Alzheimer's Disease Research Center grant, we've performed a chart abstraction looking at the records for patients seen on the UWHC Swallow Service in 2014, We've reviewed 2,035 electronic records, looked at clinical records and video fluoroscopic swallow studies. We found that 16% of these patients, 343 patients, had a diagnosis of dementia. And 90% of them were found to have dysphagia on their video fluoroscopic swallow studies. 65% of these cases would be dysphagia in the mild or mild to moderate range, 15% in the moderate range, and 10% severe dysphagia. So what happens when you suspect dysphagia in your patients and you put in a referral to the swallow service? What are the steps? Well, we have two steps involved in our evaluation process. The first is a clinical bedside evaluation. First, we'll perform a thorough review of the patient's medical record, looking for some of the risk factors for dysphagia that we know are predictive. And then we'll go to see the patient at the bedside and we'll perform an oral mechanism or cranial nerve exam, where we look at the movement of structures of the mouth and throat. Then we'll actually give the patient some things to swallow. We'll ask them to swallow different volumes and viscosities, and we'll observe for signs of dysphagia, some of these being coughing, choking, throat clearing, or a change in voice quality, a wet, gurgly voice quality that could indicate something's gone down into the airway. If we suspect that there are some issues with swallowing, we will recommend that the patient receive what we call an instrumental evaluation. And our main assessment technique for this is the video fluoroscopic swallow study. You've already seen some of these images. This is a picture of a speech-language pathologist administering barium to a patient in the fluoroscope. And this is a lateral image of the swallow study. When we think about dementia, we've already mentioned that there are some issues with swallowing and define swallowing for you. But it's also important to understand that there can be some issues in the self-feeding process. So it's not just the actual ability to swallow the material, but how do you prepare the meal to be transported to your mouth, open packages, put butter on your bread, do things like that, and then move the material to your mouth. And even that process in eating can be impaired in patients with dementia. When we're thinking about the specific biomechanical impairments in the swallow, we can use our video fluoroscopic swallow studies to give us some really detailed information about what's happening in these different phases of the swallow. And here you can see on the left 4 serial images of a bolus moving through the mouth and throat. We can break this apart and do frame-by-frame analysis of these recordings. When we're doing this analysis, we're looking at the timing. So how quickly is the bolus moving through the mouth and the throat? We're also observing displacement of particular structures involved in swallowing, and one example of that would be tracking movement of the hyolaryngeal complex that we know is so important. We can also provide measurement of some of these outcomes that I've already mentioned. So in terms of airway invasion, we have a validated 8-point scale called the penetration aspiration scale that gives us information about the depth of airway invasion, but also whether the material is cleared from the airway with completion of the swallow, and also if the patient feels that material in the airway, if they cough or clear their throat, and if they're able to get it out. And then we also have objective measurements we can do to quantify the amount of that residue that's left over. So we have a technique where we take a still image, we import it into image J. We can actually do tracing of the space in the pharynx and then look at the proportion of the residue to the total space. So that gives us, we can really then observe sort of more discrete changes in this amount of material as a result of a treatment or comparing different patient populations. So using some of these frame-by-frame analysis techniques, some studies have been able to describe the specific biomechanical impairments that occur in patients with dementia. So some studies that have looked at patients with mild Alzheimer's disease have found that these patients have higher occurrences of penetration than healthy older adults, but no clear aspiration episodes. However, there are changes in the biomechanics of swallowing that are happening in these early phases of dementia progression. These include issues with bolus transport, so having it take a longer time to move the bolus through the mouth and the throat. a delayed swallow response, which I sort of referred to earlier, where that material moves into the throat and there's a delay before the pharyngeal phase begins and there's closure of the airway. So you can imagine if that material is just sitting in the throat and you're breathing, that it can easily move into the airway. And also longer durations of airway closure. And then less hyolaryngeal displacement. So this shows how we can create an XY axis on the image and then put a coordinate on the hyoid bone and larynx and actually track how much movement there is of those structures. In patients with moderate to severe Alzheimer's disease, we start to see more occurrences of aspiration. So it's estimated that 1 in 4 patients with moderate to severe AD will aspirate on the swallow study. But the disorders that we observe are actually fairly similar. So ineffective bolus transport, prolonged transit times, and residue in the pharynx, which you can see in this image here. A delayed swallow response, which you'll see in this swallow study, the material actually moved into the throat and just sit there before the airway closes. And decreased opening of the esophagus. So it seems that at these later stages in dementia progression, these changes have now become pronounced enough to actually influence the outcome of safety, so that we start to see that material entering the airway. We also observe something that's been termed swallow apraxia in patients with severe dementia. This is where there's difficulty moving the material out of the mouth and into the throat. And this is an example where you can see the patient moving their tongue around, trying to get that material back into the throat, but just having some difficulty initiating that process. And several studies have also compared dementia subtypes and looked at the different swallowing impairments in these different groups. This study examined patients with Alzheimer's disease and vascular dementia. And you'll see that in the Alzheimer's disease group, the impairments tended to occur more in the oral phase of the swallow, whereas in vascular dementia, there's more pharyngeal phase impairments. There's certainly some overlap in terms of the slowness of the triggering of the swallow and that material being left over in the pharynx. So while we have these studies, cross-sectional cohort studies, that give us some information about the specific impairments at each stage of dementia progression, we don't have a well-designed longitudinal study. And more recently, we've had some techniques that have been developed that would really have nice application in this type of longitudinal design, where we could really characterize what these impairments are over the progression of the disease. This is an example of a technique that we use in my lab called Computational Analysis of Swallowing Mechanics, or CASM. We can actually place, you'll see the green are the coordinates placed on the different anatomical structures. And then using a MATLAB program, we can actually track the trajectory of these coordinates and then consider their movement in relation to one another. So we're not just looking at movement of one structure, but overall shape change of the pharynx. Here at the University of Wisconsin-Madison, Dr. Tim McCullough and his doctoral student Corinne Jones, who's here today, have worked really hard to apply high-resolution manometry that was developed for the esophagus to the pharynx. And this is a really useful tool that I think has application to the dementia population, in that swallow studies don't give us information about pressure generation. They tell us about the impairments within the swallow, but not the pressures that are being created that could actually provide some targets for treatment. We also have some novel imaging techniques that have been developed for swallowing. In Japan, they're using three-dimensional computed tomography, which provides more information than we get from that two-dimensional view on video fluoroscopy. And here at the UW, in collaboration with Dr. Klewer in radiology, we're working on developing some ultrasound measures of the tongue that will give us information about elasticity, blood flow, and also tongue contour using three-dimensional ultrasound. So then in thinking about the biomechanics of the swallow, what are the specific issues in self-feeding that we observe? This was a study looking at patients with mild AD where they presented a meal and then tracked how they did with these different tasks that are involved in sort of getting ready to move the food to the mouth to swallow. And they found that patients with AD were more likely to receive cues from their eating partner than healthy older adults, and that this need to be cued or fed increase the risk for pneumonia and mortality in patients with dementia. So you can imagine that if you're being fed by someone and you're not quite ready for that next spoonful, but they're not really able to read your cues, that they're just kind of moving forward and putting things into your mouth. And so not being able to control that can increase issues with swallow safety. So then in understanding the specific problems in swallowing that occur in dementia, what are some of the underlying causes of these impairments? The first that I wanted to talk about were issues with strength. So we know that there are aging-related changes that happen with swallowing, and we term these changes presbyphagia. We consider them to be within the normal range for older adults. One of the main contributors to these age-related changes is the process of sarcopenia, which is a change in muscle mass and quality with advancing age. Most of the studies have looked at how sarcopenia affects the muscles of the limbs, but very few have focused in the head and neck musculature. We do know that the tongue muscle fiber diameter decreases with advancing age, and these are MRI images showing the tongue, changes in the tongue in a young and older female. And you'll notice in the image on the right, the tongue mass overall is decreased, and there's also more fibrotic tissue within the tongue in the older female. So we actually have a way of measuring tongue strength. We can ask the individual to take their tongue and push up against a pressure bulb as hard as they possibly can against the roof of the mouth. We call these maximum isometric lingual pressures. And we know that these pressures decline with advancing age. However, the pressures that we need to finish an efficient swallow do not seem to change with advancing age. So the difference between these isometric pressures and swallowing-related pressures has been termed functional reserve. And the thought is that as we age, the pressures decline and put us closer to crossing over into what we need for successful swallowing. So we also know that maximum lingual pressures are associated with other measures of physical function. Dr. Bering here at UW in the GRECC did a study looking at isometric lingual pressures and their association with jumping mechanography and grip strength and found positive significant associations. Decreased tongue strength is also a risk factor for aspiration. And when we think about dementia specifically, a recent study looking at 693 patients in long-term care who had an average score of cognitive impairment in the moderate range were found to have decreased tongue strength compared to normal, and this reduced tongue strength was associated with longer meal times, reduced food consumption, and the presence of observable signs of dysphagia. Oral sensation is also a contributor to swallowing impairment in patients with dementia. We know that taste sensation decreases in AD. Olfaction, which has been found to influence taste, is also impaired in AD and has been shown to be an early predictor of the MCI to AD conversion process. Lingual tactile acuity decreases with age, and oral tactile thresholds increase. So definitely some changes in sensation that may impact the ability of the patient to recognize food and also to control the bolus in the oral cavity during that oral phase. Motor planning is also thought to be an issue. Thanks to some fMRI studies out of the UW as well, we were able to look at blood oxygen level dependent signals during swallowing, and it was found that there were group differences between patients with mild AD and healthy older controls in areas that are known to be active in the swallowing process. All of these areas receive input from the insula, which is known to be atrophied in early AD, and to be involved in the swallow planning and initiation process. There's contributions of cognitive dysfunction to the process of swallowing. We know that patients who are not oriented or have difficulty following commands are at increased risk for aspiration. And studies that have had individuals swallow and do another cognitive task at the same time have shown that those patients have issues in the oral phase of the swallow, as well as decreased swallow safety. And finally, there's a role for lubrication to efficient swallowing. Patients with AD have been found to have lower salivary flow rates than normal, which has been attributed to autonomic nervous system dysfunction in this population. And altered saliva production contributes to oral health. Poor oral health has been shown to be a predictor of pneumonia in older adults. And the ability to perform oral hygiene is really affected in patients with dementia. There have also been some studies that have looked at oral microbiome shifts in patients with pneumonia. So there may be some changes in the bacterial colonization in the oral cavity in these patients that predispose them to pneumonia once they develop dysphagia. So based on these known causes of dysphagia in this population, I've developed a conceptual model of dysphagia in dementia. So here in this box, you can see the various mechanistic factors that contribute to swallowing biomechanical impairments, which then lead to these swallowing outcomes of safety and efficiency. These lead to the health outcomes that I've already mentioned. And then there are some other confounding variables that we have to consider that may also contribute to these negative health outcomes in patients with dementia. So now that I've given you an overview of the contributors or the causes underlying swallowing impairment in this population, I think it's important to shift and discuss what we can do about it. How can we address this problem? So what's our current approach to dysphagia management in this population? Most often, the speech-language pathologist will become involved once the patient is admitted to the hospital for dysphagia or another medical issue. We're not often integrated as part of the interdisciplinary team managing the care of these patients early on, so we're kind of coming into the picture with little information about what this dementia progression has looked like over time for that patient. As inpatients, these patients also have other issues, such as delirium, which complicates the picture and can make it difficult to sort of get a good idea of what swallowing function looks like. And it can also be difficult to engage the caregiver when patients are in the hospital, because they're often distracted or can't be there because they're at work. So that is really a key component in terms of education for swallowing. So what usually ends up happening is that we'll send these patients for a video fluoroscopic swallow study, and due to the confines of some of the issues related to hospital admission, we'll usually recommend what we term compensatory approaches. So we'll ask the patient to change the position of their head or to modify their diet, thicken their liquids, or change the consistency of the food that they're eating. So I'd like to propose a paradigm shift today. This graph shows the progression of cognitive impairment with dementia advancement. And we don't know at this point, as I've already mentioned, whether the dysphagia progression mirrors the progression of dementia. This is something that we really need to look at more with longitudinal studies. But if we're able to intervene early with rehabilitative intervention, I think it's possible that we may be able to change the trajectory of the swallowing decline with the goal of maintaining swallow function for longer into the disease process. While we know that we'll likely end up at the same place in terms of late-stage dementia, the space that we can gain between these different trajectories gives the patients more quality of life and preserves the joy of eating. So with this goal, what are some of the targets for rehabilitative intervention? The first can be increasing muscular strength for the swallowing-related musculature. And we know that strength training for striated limb musculature in patients with early-stage AD has shown improved gait and balance, increased physical activity, and also decreased fall risk. Progressive resistance training applied to the bulbar innervated muscles of the head and neck can have similar effects. We also need to think about how we can enhance lubrication. So strengthening the muscles will not address these issues with lubrication that provide resistance to flow of the bolus through the mouth and throat. So one option is to consider application of a saliva substitute, such as Biotene, which is an oral moisturizing gel. This product contains xylitol, which is known to stimulate salivary flow and also optimize oral health. I'm the director of a clinic at the VA called the Intensive Dysphagia Treatment Program. This clinical program was founded at the Madison VA in 2012. It is, as Dr. Page mentioned, funded by the Office of Geriatrics and Extended Care as a clinical demonstration program, and we've expanded to 8 sites nationally with 2 more to be added this year. Through FY17, we had 281 patients enrolled with a mean age of 70 years. Some of the key components of this program are an interdisciplinary team approach, device-facilitated progressive resistance exercise-based therapy, one of these being lingual strength training. And for a large number of our patients, we utilize a device that was actually developed here at UW-Madison in the GRECC by Dr. Joanne Robbins called the Swallowir device, and you can see that pictured here. And this device has a mouthpiece with 4 embedded pressure sensors, and the patient pushes up against these pressure sensors with their tongue. And then the resistance or the targets are increased over an 8-week time frame to strengthen the tongue. We've seen outcomes such as improved swallow function and quality of life, as well as decreased hospital admissions and pneumonia diagnoses in patients who've been through this program. About 10% of the patients who've come through this program have some level of cognitive impairment, and they've been able to complete the protocol by having a supportive caregiver involved. We've observed many of these positive outcomes in patients with cognitive impairment, showing that this is a feasible strengthening approach to be applied to the dementia population. I've also conducted a pilot study looking at 42 healthy adults across the age range. We asked individuals to rate their effort with swallowing and also their level of mouth dryness on a visual analog rating scale that you can see pictured here. After they applied the Biotene Oral Moisturizing Gel, we saw significant decreases in effort with swallowing as well as mouth dryness, supporting that this may also be a useful intervention approach. And so based on these pilot data, I've submitted a K award to the National Institute on Aging, which is currently under review. And the goal of that project is to look at these interventions, use of a salivary substitute and lingual strengthening, in patients with early stage Alzheimer's disease to determine within a randomized controlled trial design what effects these interventions will have on swallowing-related function. So finally, I'd like to conclude by talking just a little bit about specific considerations for patients in the late stages of dementia. And I'd like to point out what I consider to be 3 dysphagia myths about how we should manage swallowing issues at this stage of progression. The first is that the speech-language pathologist can only provide recommendations if they have an instrumental evaluation, such as video fluoroscopy, and that our modifications that we'll recommend will consistently negatively affect quality of life. I'm here to tell you that is not true. We can provide a lot of really useful information through our clinical bedside evaluation if we understand what the patient's goals of care are and what they're looking to accomplish. We can observe the patient swallowing. We can look to see what types of consistencies will minimize symptoms of dysphagia, but also thinking about that in the context of quality of life. Another common myth is that feeding tubes will prolong life and also prevent aspiration and subsequent pneumonia in this population. We have several studies that show this is not true. So the lifespan is not extended by putting in a feeding tube. While you're eliminating aspiration of food and liquid being swallowed through oral intake, you're not eliminating aspiration of saliva or material coming back up from the stomach and into the airway. And so the risk of pneumonia actually does not decrease with feeding tube placement in late stage, and this definitely affects quality of life. And finally, more recently, I've heard several clinicians mention that they really felt they needed to take into account the patient's quality of life, and so they went along with the patient and caregiver's desire to go with an unrestricted diet. I think it's really important to consider that when a patient is on a diet that isn't physiologically appropriate for their swallowing, they are at increased risk for asphyxiation. And just thinking about how awful it would be to be at the table during a meal with a loved one with advanced dementia and experience, asphyxiation during meals. So this is definitely something to think about. Also, the experience of dysphagia itself is not pleasant. So if you're coughing and choking throughout a meal, That's really not enhancing quality of life. So when we're considering our recommendations in these late stages of dementia, we have to look at this through a lens of goals of care. We have to have conversations with the patient and the caregiver to understand what they're really looking for from the speech-language pathologist evaluation. And we're always balancing quality of life and swallowing safety. So it's possible for us to optimize the safety of the swallow while also considering the patient's preferences and goals and working with the family. It's also important to consider when we think about mealtime more broadly in the eating process, there's a lot more that goes into that than just accessing the food through swallowing. There's also the quality of the food that's being presented. Is it palatable? Is it appetizing? And also the environment, enjoying social interaction with others as part of that mealtime process. And then we also can think about, outside of just optimizing swallow safety and improving swallowing biomechanics, there are other things that we can do to minimize the risk of the negative health outcomes in this population. So we can think about adequate oral care and oral hygiene. We can enhance the nutritional content of what's being taken in. So even within a modified diet, are there ways that what's the nutritional aspects of that food can be enhanced for the patient? The preparation of the food, is it appetizing and palatable? I was just floored when I was in Japan to see that the effort that's put in to making sure that the food that's presented to older adults maintains the form, that it looks like sushi, and it's in a sushi dish. You know, things that are just sort of common sense that we all enjoy in the mealtime experience, but we don't often think about here in the U.S. And also encouraging physical activity in our patients as much as possible for lung expansion will also minimize the risks of aspiration. And finally, eating strategies and mealtime contexts being optimized. I also think it's critical that we involve caregivers in the education. We know, I just completed a study here with my colleague, Dr. Gilmore Bykowski in the School of Nursing, where we looked at videotapes of patients with dementia during mealtime. And we were able to code whether the caregiver was using more of a task-centered approach to feeding, so whether they were really just sort of focused on getting through the meal, or if they were using more of a patient-centered approach, where they were taking cues from the patient, sort of following their lead. And the caregivers who used the patient-centered approach, we saw fewer signs of dysphagia with that approach. So definitely the feeding approach can influence swallowing safety. We also know that caregivers of patients with dysphagia have higher anxiety and therefore greater caregiver burden. And so if we can provide caregiver education and training and also engage caregivers in this process, I think that's huge for the patient's experience. Thinking about the home context, the patient's preferences and goals, and also the ways that we can provide support to caregivers. So in conclusion, I have some key points I'm hoping that you'll take away from this talk today and be able to apply clinically. Swallowing changes occur early in the dementia progression. And so early intervention may be able to change the trajectory of some of this dysfunction. An interdisciplinary team approach is key, and involvement of the speech-language pathologist throughout the entire dementia progression will be critical. We have to consider goals of care. So while we want to maximize oral intake, we have to balance that with issues related to swallowing safety. And finally, we need to be sure to engage caregivers, provide training, and provide support. With that, I'd really like to take a minute to acknowledge my incredible mentoring team, the division head for Geriatrics and Gerontology, Dr. Asana, my primary mentor on my K-word, Dr. Kind, and also my staff in the lab at the Swallowing and Salivary Bioscience Lab, as well as my clinical colleagues at the VA, as well as the UW on the Swallow Service. And with that, I'd really be happy to address any questions that you have, and I'm hoping we can have some discussion.
Thank you so much. I'll ask Dr. Rogus-Pulia to call on the audience, and please repeat the questions.
Yes.
So that was fabulous. I just think all definitely needs to see it again sometime. So I'm a primary care physician, and in that moderate Alzheimer's disease group, what I found
Yep, so the question was, how do we approach patients in more of the moderate stages of dementia progression who are having difficulty with adherence to some of our dysphagia-related recommendations, such as thickened liquids? I think this is an issue in our field broadly. There's actually overall very poor adherence to the recommendation for thickened liquids across our patients. I think one of the key pieces here is education. And what I find is that if I can actually use the swallow study images, and I don't know if that is an option for you, it may not always be, to show patients what's happening when they're swallowing, I think that can be, really powerful to actually be able to see the images. And then I also think it's important, I think part of the issue of what's happening right now clinically is that I think patients look at that as sort of a long-term solution, and it may be that we can provide some rehabilitative approaches to increase strength of swallowing muscles, so that may not be something that has to be, as long-term as thinking about something more temporary. So I think those are some things that can be used, but it's definitely a difficult issue. Some other things that have been raised in the literature are taking thin liquids in between meals. So taking the thickened liquids during the meals to optimize safety during mealtime, but then doing aggressive oral care in between meals and allowing patients right after doing that oral hygiene then to take some water. And I think that can sort of be a bit of a middle ground. It's called the Fraser-Free Water Protocol, but we don't have quite enough data yet to support it in the dementia population to show that there isn't increased risk of pneumonia with that. But I think that's something to consider as well. Yeah, no, that's a great question. So the question was about use of postural adjustment to optimize swallowing function in patients with dementia, or just older adults overall. Yeah, this is something that is, I think, been looked at quite a bit in the literature. And another thing that I noticed in Japan is that there's actually a really strong focus on optimizing posture in older adults there. So they've actually even created chairs, swallow chairs, that people can sit in to sort of optimize the posture. It's something that I think we need to look at more. We do change the posture, though, of the head. That's something that we do commonly to change the flow of the bolus through the mouth and the throat. So we'll have people tuck their chin or turn their head. Sometimes that's just not possible, and especially if you have kyphosis that's set in, it can be more difficult to use those adjustments. But it's definitely something I think that can be used, and I think of it sort of in the category of more eating strategies, ways that we can sort of, maximize the strategies that we're using. So pacing the meals, optimizing posture, engaging the caregiver. So I think that's a great point, yeah. Dr. Barsi? Absolutely. So the question is, what about the influence of medications in older adults and patients with dementia specifically on swallow function? And I was really excited to see recently there was an article discussing the use of neuroleptics and how they can contribute to pneumonia risk in patients with dementia. And then there was an editorial that followed that actually talked specifically about swallowing, which I thought was really encouraging because we see this quite a bit in the literature that use of neuroleptics increases the risk for dysphagia, or for pneumonia, but without sort of that other piece of swallowing being part of it. So we do know that neuroleptics can have an effect on swallow function, and also the issue with polypharmacy in older adults in that many of the medications that they're taking also affect salivary flow. So that's also sort of a key issue. We don't have any really well-designed studies that have pieced this apart as of yet. We have long lists of medications that may potentially affect the swallow, but I think that's something that we need to look at in more detail, and it is actually one of the pieces that we're pulling out in this chart abstraction project. So we'll be able to look at specific classes of medications such as anticholinergics, to see whether there may be some association with swallow function. Yes?
Can you comment on
So the question is about reflux and acid inflammation and how that may affect the laryngeal structures. Yeah, so we definitely know that there are issues related to reflux that can occur. And what we see in older adults is a higher occurrence of intraesophageal stasis, which is where the material moves into the esophagus but doesn't actually move down into the stomach, sort of stays in the esophagus, and then can actually come back up into the pharynx. It's termed laryngopharyngeal reflux. And when that happens over time, there can definitely be damage to the structures in the larynx, including the arytenoid cartilages and the vocal folds. And that material can be aspirated into the lungs, leading to an aspiration pneumonitis. So it's definitely something that needs to be examined. And we actually have a strength here at the UW hospital where we can do a combined swallow study and esophagram. So if there is concern that there may be esophageal motility issues for the patient that are leading to reflux, that's something that we can look at during our swallow study so that we get the information about the oropharyngeal mechanism, right sort of at the same time as we're getting that esophageal information. It's definitely something that needs to be considered.
We have time for one quick question, one quick answer.
Yeah, thank you for that question. The question is, do we have a screening tool that can be used in the clinics for patients with mild MCI or mild dementia that may be able to detect some of these issues in swallowing? So we do have a technique called the water swallow test, 3-ounce water swallow test, where we will give patients 3 ounces of water to drink consecutively, and we'll have them provide vocalization before they drink the water and then after, and we'll look at changes in voice quality from before to after, so wet, gurgly voice quality, coughing, clearing the throat, signs of aspiration. Unfortunately, that test has really only, at this point, been validated in the stroke population, so we're looking to do some validation of that in patients with dementia, but it's certainly something that can be used at this point. It is sensitive to aspiration, but not to other issues related to swallowing. And so I think in conjunction with that, it's useful to use a patient-reported outcome measure. And we have a tool that's been developed called the Eating Assessment Test that has a list of 10 questions related to swallowing. And there have been some cutoff scores developed with that. It's been validated against video fluoroscopy. So I'd be happy to provide more information about that tool if it would be useful. But we're working on validating that in patients with dementia as well.
We've got to close there. I learned so much this morning. I want to thank you. I appreciate your team being here in support. You're always welcome at Medical Grand Rounds, and please join me in thanking Dr. Rogus-Pulia for an outstanding Grand Rounds.